Now, I would like to welcome Ellen Mckechn, who is a professor in the School of Public Health Sciences at the University of Waterloo, Canada. Her research examines return to work, vulnerable workers, and the work and health impacts of precarious employment. Her latest studies examine how digital platform and low-wage workers are managing their health while navigating the COVID-19 environment. Mckechn's 2019 edited book, The Science and Politics of Work Disability Prevention, provides an international picture of social security systems, work, and health. She works closely with community partners and policymakers to ensure research relevance and improve research impact.
Thank you so much for inviting me here. I'm really pleased to be here today. So I'll talk about my title. The title of my talk is Understanding Mental Health and Opioids During Return to Work, but in the end I focus my talk mostly on drug use and opioids. So just to sort of set the context a little bit for this, thinking about injured workers and drug use and looking at some recent research. So earlier studies basically have been finding that opioid use is associated with worse return to work outcomes and higher rates of psychiatric illness. I was struck by a 2020 study of West Virginia workers' compensation claimants that found that compared to the general population, mortality from accidental poisoning of injured workers was significantly elevated among the overall cohort and lost time claimants. Most deaths from accidental poisoning in the cohort were due to drug overdoses, including opioids. If confirmed, these findings point to a largely unrecognized and substantial source of mortality from occupational injuries. So this really struck me and made me think about, how injuries are measured at return to work and what outcomes are actually attributed to being on a claim. But another thing that struck me about this study was that they jumped immediately to the solutions of faster return to work and reducing opioid prescribing. And so the question is, well, what is going on with injured worker drug use during return to work? Is it opioids that are causing the worst return to work experience? That was what the Martin et al. Study was suggesting. But the thing with these quantitative studies is that they find associations between two things, and then they start guessing about why the association is there, right? They have this top-down sort of deductive approach. And so people just seem to automatically go to the idea of faster return to work all the time. But what if we turned that proposition upside down? What if we considered that it might be return to work experience that causes worse injured worker drug use outcomes rather than, having a faster return to work being the solution? And so this would be an inductive approach to return to work and drug use rather than a deductive one that tries to guess at why there's these associations. So today I'm going to be drawing on quite an older study of mine done in 2009. To my chagrin, these particular results weren't published, although I've been talking about them a lot. But it's still relevant because not much has changed. And I will talk about the policy context and what has changed since 2009 a little bit later on in the study, but not much. So my focus on return to work and drug use were unexpected results from a larger study of workers with complex problems with return to work. And it involved in-depth interviews with the workers to understand their situations. So this was the larger study. And it was the main question. We want to know why injured workers didn't fail to work as expected. But in this, what I'll be talking with you about today, we're focusing on the injured worker medication use. But we conducted interviews with 48 injured workers and with a lot of different service providers as well. And one of the things that struck us from that study, we did ask them about what medications they took while following their injury. And out of the 48 workers, 20 of them were taking opioids. Now, this was a select population of injured workers in that they'd all been on claims for 3 months or more. But it was still a lot. And so I'd like to share with you now some findings from that study about why injured workers took drugs. And we identified 3 key reasons: being able to manage early return to work. We identified no-win situations, and then also the phenomenon of worker overcompliance. But before I do that, I want to make sure that we're all on the same page about the WSIB's philosophy of early return to work. So back in 2009, when we gathered these data, they talked about most people who have a workplace injury or illness are able to return to some type of work even while they're still recovering, provided the work is medically suited to the injury or illness. Returning to daily life, work and life activities can actually help an injured worker's recovery and reduce the chance of long-term disability. Just going on WSIB's website this week, I can see a lot of this language is similar, where they say appropriate and early return to work maintains the dignity and productivity of a worker that plays an important role in the worker's rehabilitation and recovery. So there has actually been some change. Instead of only talking about medically suited, there actually is mention now of dignity and productivity, which is progress and good to see. But what isn't mentioned in either of these policy statements, but is critically important to the return to work process, is that early return to work means cost savings, both for the WSIB and for the employer's experience rated WSIB insurance premiums. And that is a very, very important subtext to the situation. Okay, this is interesting. Here we go. Okay, so the first thing I want to talk about is medication to manage return to work conditions. That's the first theme. And so, you know, there were 3 main reasons that we talked about. One of them was medication was needed in order to keep moving. So we found that workers in our sample were returning to work while they were still on significant pain medications. And an important concept underlying principles of return to work is the principle of hurt versus harm. So that means that pain might hurt the worker, but it won't harm the worker. So within the logic of early return to work policy, pain is acceptable during return to work. And the work can, and the activity can even have a therapeutic effect on the worker. So, so in this quote that I'm about to share, you'll see the emphasis on keeping on moving. And just to mention, there's names on all of the quotes, but they're all pseudonyms. They're not the real names of the people we spoke with. So here is someone who we called Gideon, and he talks about being on I was on different medications before, and I can't name all of them now, but now I'm on codeine. The doctor won't take me off of it, and we've tried to cut back. He won't let me cut back too much because then it impedes my physical. You have to keep moving. You still have to keep doing stuff. And that's what it comes down to. Another reason was workers took medication to keep their jobs. And so in some cases, the pain may not be clear, but it's not a reason to not return to work, right? With the hurt versus harm philosophy. So it means returning to work and attempting to manage that pain. So one way to manage such situations is by medication use, right? So that they wouldn't lose their jobs. So here's an example from a worker who said, the doctor sent me back to work. I could hardly walk. He said, if you don't go back to work, they'll fire you. So I went to work. But with all of these Percocets, I was just checking pistons in this bin, and I couldn't bend, and I couldn't get anyone to listen to me. A third issue was that pain was needed to cope with the poor working conditions. So what we saw in this study was medication overuse in situations where the work wasn't properly modified. In these cases, the injury might be quite clear, but the worker is simply not being properly accommodated in the workplace. On paper, the employers might report to workers' compensation that the work has been modified, but in practice it is not. And so in these cases, we saw workers strategically using medication to manage the pain that's caused by these difficult return to work situations. And so here, for instance, is a worker who talked about A few months later, I ended up multitasking on the job instead of doing the accommodated work I was supposed to be doing. So this worker did have accommodated work sketched out, but the employer kept saying, hey, we need help with this today. Can you do this instead? Or these types of requests. He said if I didn't multitask, I was out of a job. So we went up to another big painkiller. I was on 100 milligrams twice a day, and I went up to 200. So in various situations, the workers found themselves in situations that were difficult to cope with physically, and that they managed in the only way that they could, which was taking medication to cope. And so they ended up in these types of no-win situations where the worker takes medication to cope with the system requirements related to return to work, but by taking that medication, that in turn creates new dysfunctions. So in this example that I have on this slide, a worker has been placed by workers' compensation in a work retraining program because his injury didn't allow him to return to his former workplace. He was in pain and he was taking medication to manage it. But the medication use meant that the worker couldn't benefit from the retraining because the side effects meant that he couldn't concentrate on what he was supposed to be learning. And so it looked like non-compliance, and then the worker could lose benefits, which is an example of a no-win situation. So here is an injured worker peer helper describing a situation. He says, now you're in school and you're popping pills for the pain. You can't remember what happened yesterday, what the teacher said today. You ask for a chair. No, you can't get a chair because that's ergonomic. You're not sure which way to turn, and you start missing some time. Then you get a letter saying you've missed so much time at school. If you don't pick up, you're cut off, and you get zero benefits. Another no-win result of worker use was being placed in jobs where the medication consumption posed a significant health and safety hazard, not only to themselves, but also to others. And so the point in these situations is that we're seeing an overriding focus on getting the worker back to work, but no serious focus on the worker's actual situation. So here is another quote from someone who worked in a mine. He said, it was very uncomfortable. Believe it or not, the type of meds I was taking, I shouldn't have been allowed on the mine site, and especially with this equipment. Nobody thought about it. Here I am operating a hoist, and I'm carrying 20 men at a time and carrying explosives and fuel. So this brings us to the third issue that we saw, was the issue of worker overcompliance. So why do workers go along with these situations if they're aware that they're wrong, right? Sometimes it's only on reflection in these interviews that they think about it. Why did I do this? But a key issue is that workers are afraid to complain. And that was a key finding of our larger study. Many of the workers with return to work problems were terrified of losing their jobs and losing their benefits. And so they were bending over backward to try to go along with anything that was being asked of them. And medication use was a readily available way to manage compliance when the situation being asked of them was unreasonable. And so here's another peer helper talking about that situation as well. She said, the worker typically doesn't tell WSIB when modified work is inappropriate. They're very fearful of their benefits and income. And because they're fearful of their income, they'll put themselves in situations where they shouldn't put themselves in. So that's in a nutshell some of our results. And what I'd like to turn to next is to consider worker medication use in policy context. And this was what brings us to what I see as two key policy challenges. The first is rated premiums. So they provide employer incentives to rush return to work. And so for people who aren't familiar with the way it works, is basically for every day of lost time for a work-related illness or accident injury, the employers at the time saw hefty premium surcharges for every day of lost time, right? So it was a sizable amount. And if the employers reported fewer accidents than expected for that type of work, they'd also get these huge rebates. The idea between these financial incentives was that it was supposed to drive employer accommodation of workers so that workers could recover while they're working. But there's what we might call side effects of this policy, where employers protecting their financial interests. And a quick way to save money is by not reporting the claims at all. That would actually lead to a rebate at the end of the day, if they didn't report very many at all. And another way is by reducing the lost time, right? Rushing workers back to work, even if they're not ready. Now, there were so many criticisms of experience rating. And so in 2020, quite recently, there was a new rate framework that was unveiled, and they talk about removing premium surcharges and rebates. But if you look closely at the policy, injured workers still begin to cost the employer starting the day after the injury, affecting what they call their predictability of injury costs rate. So injured workers are still a cost. A second policy that I think is an important context for thinking about how injured workers are treated at work, and how that ties into medication use, is what I call the hyper early return to work policy of Wsib, which is extreme. Workers have to return to work the day after the accident or injury, or the employer's premiums start going up. So other jurisdictions actually give space to employers and workers to manage the situation before the social insurance or workers' compensation system kicks in. So for instance, in Germany, the employers and the workers have 6 weeks to work it out before workers' compensation kicks in. In Sweden, they have 2 weeks. So basically that time gives the workers time to go to any doctor's appointments they might need to go to, which is reasonable because they've just had an accident or an injury. They might give them time just to sort of rearrange their lives a little bit in the context of their new health situation before going back to work. And the employer has leeway to give the worker time off work during that time if they want to. It also gives employers time to plan thoughtfully for modified work. But we're extreme. And it's not just us, it's also present in the US and Australia as well. But compared to European jurisdictions, it's very extreme. So how can we do better? Well, thinking about some of the situations that I've been describing, we could definitely have improved communication venues about return to work problems, and that's something that Fergal referred to as well. The difference between 2009 and now is we actually have return to work specialists who visit workplaces when planes are drawn out or there seem to be problems. So that's very good. But there's not so many of these people out there. We still basically have a self-reliance approach where employers and workers are expected to work it out on their own. We can also have a system of worker advocates. So employers have all sorts of expert advisors helping them to think about how to manage workers' compensation claims. But if you're not from a unionized workplace, and many workers are not, there is hardly anyone to go to. We do have the Office of the Worker Advisor, but they have huge waiting lists and they're up to their ears in complex claims. So just what about, someone who's sort of thinking about the workers' needs, just providing them advice, even a call-in line. We could do something like that. We could have careful monitoring of workers while they're returning to work on significant meds. To their credit, the functional ability form that doctors fill out to describe the situation of the workers now actually includes this little category. Oh, and my yellow highlight is moved to the wrong place because of the slides. But basically, underneath here, there's potential side effects from medication while on that's included now in the restrictions. It's kind of funny because it's right beside like work at or above the shoulder activity. It's kind of just thrown in there. But there is actually now an opportunity for the physician to talk about how the potential side effects from the medication may preclude certain types of work or going back to work at all. But I don't know very much about how that's used in practice, but it's actually good to see it on the form now at least. Another thing we could do is remove employer financial incentives to rush return to work. The recent rate framework that was introduced muted some of the experienced rating effects of workers, so they don't get sudden surcharges now based on the accident. But the financial liability to the employer of the employee missing work due to an accident or illness remains. And I suggest, and I work with people in Onawig and injured workers consultants, and the need to separate worker health from employer costs so that the focus is on workers' safe recovery and not on employers saving on costs. So just my final words here. So much of the research out there assumes that earlier return to work is the solution to problems such as medication use and chronic illness and unemployment. And that's generally conclusions drawn from top-down sort of deductive logic. Our interviews with workers led us to look at the situation in the opposite way. We started to think, what if it's the process that causes the worst opioid outcomes? And so our data suggests this may be an important part of the story. And typical researchers say, well, more research is needed. But this was qualitative research, which is very good for generating ideas about complex causal circumstances. And I think we definitely do need to look into this more. These are just some references that I included in this presentation. And yeah, I'd like to thank you and to acknowledge the funding that we received to conduct this original study. Thanks.
Great, thanks. Thanks a lot, Ellen. Once again, very thought-provoking and still very relevant today, I guess. The conversations that, like, even if it was from 2009, the same kind of things are happening today, and it's still some insights. I guess I don't see any questions in the chat. I don't know if anyone has any that if they want to raise their hand or speak up, but
if I could just mention one more thing, because of limited time for this presentation, I didn't talk a lot about the return to work stakeholder guide for workers with mental health challenges that we also devised, and so I'll put a link to it in the chat in a few minutes.
Yeah, that's great. That's very helpful. And I guess my question is more around, Michelle's raised her hand, but I have a question, like, I guess, are there glimmers of hope, I guess, or just thinking about how once again, can we translate this for a meaningful difference in the workplace? So the workplaces are driven by premium costs, but they also are driven for long-term relationships with their employees and safety and health and all that. So so are there other ways we can influence things, I guess, even within this sort of compelling WSIB structure?
Yeah, well, I've also interviewed a lot of employers across my studies, and employers don't like this either, because they might have great relationships with their workers, and they talk about, like, I say, I really don't like asking them to come back so soon, but for financial reasons we have to. I would much rather give them a week or two off and then have them back. So it actually is a policy that disrupts the positive relationships between employers and their workers sometimes. And I think that WSIB has heard this partly. They've tried to change it with the rate framework that makes things a bit better for employers, but the sort of underlying issue of workers being a cost is there. But the employers are speaking up, and a lot of them do have very good relationships with their workers, and sometimes they just they have. But if they give the workers a bit of a break and a few days off, they're doing it illegally or without reporting it.
Hmm.
Yeah.
Okay, thanks. Michelle, you had a question? And
yeah, thanks so much for this presentation and all your work that you've done around this. And you may or may not know that I'm an occupational health nurse with OCal, and so have had, let's say, much occasion to interact with workers and with WSIB related to some of the issues that you've mentioned, and particularly the response, like perhaps at the adjudicator level. So on occasion, although rarely, I have found an adjudicator who really gets it, gets the dilemma, gets the problem, gets the interference from WSIB as being negative, and their hands are kind of tied, but they recognize it. And so in some instances, their interactions with workers are supportive, and in other issues, they don't know what to say. And so it's kind of goodbye. So a couple of things, given that this is about mental health, for one thing, I am, as they say in some talk, I'm making up that these WSIB adjudicators may be experiencing stress and certainly conflict about their job role and the impact of that. And so I am wondering whether there has been any talk or studies around looking at that from an anonymous perspective or whatever, and to use that in terms of making differences for workers.
I've actually written about that. I did a study of what we used to call the labor market reentry program. Now it's just called work transition program. And my research was part of what's prompted WSIB to look into the program more and think about revising it. And in my a study that I published that was called the ability paradigm, we talked about the people in the labor market reentry system feeling torn about the position that they're put in. They really didn't like that situation worked at all, and it made them feel awful. And that was very difficult for them too.
Thanks. Fergal, did you have something else you wanted to add? I wasn't sure.
Just that there's a lot of ill health and problems that go on outside of the compensation system. And I think that's important to remember. Many more issues are coming up in the context of private disability insurance and other, well, EI, sickness absence, and these kinds of things. And I think, there is a certain pressure on employers to up their game because of that phenomenon of the mental health claims on the rise and other things and just productivity issues that are caused by, like, a lot of people work with physical pain problems without making compensation claims. And so, and I shouldn't, what I'm trying to say is that employers, I think, are being pushed in from other directions as well. So
that's a good point.
And hopefully, that will kind of raise the bar for everybody.
Thanks. Yeah, and I think that is a good point. Anyways, there's so many issues to talk about with respect to WSIB and the claim system that that there are a lot that are relevant, and they do have impact on mental health and on addiction, and on our discussion too about opioid harm reduction. Kathy, you had your hand up. Do you want to?
Yeah, I did. Thank you. Great presentation, great conversation. I like your concept of taking things and flipping it on its head. So I've got a question for this group. Since I have you here, I'm with IHSA, and I attend a lot of labor management meetings throughout the construction and utilities, transportation industries. And I had a really interesting conversation with a few different groups now, and they have posed a question to me, and they want me to dig up an answer. And I thought, well, maybe I'll use this as an opportunity to ask you guys. So we know that WSIB, to your point, is an issue when it comes to the dollars and making individuals a dollar, not an individual, right? They become a focus of a cost to the employer. What I've been finding is there's been some great employers who want to support their worker on a return to work. But a lot of people in the construction industry, or a lot of employers, they're actually contractors. They're contractors to bigger companies, right? They have these big employers that they report to. And what I've been finding is that the contractors themselves are getting resistance from the big employers. If your worker goes off, they don't want them back. So, especially around addictions and opioid use. So, if you get caught, caught, and I put that air quotes around that. If you're laid off or sent home due to an opioid issue or an addiction issue, whether you're ready to return to work or not is irrelevant because you're banned. You're banned from going back to that employer. So how do we address that? It seems like it's a human rights issue, but it's a reality on the ground. Many people are
Yeah.
worried about getting fired, right? Like, or just having a life ban on certain companies. So have you guys come across this, and how have you
Yeah.
challenged it? And
Yeah. So yeah, I hear you. It's a funny thing because the more responsibilities we add on to employers, the more legal loopholes start being used, right?
Mhm.
It's like there's this threshold, and we see in our economy a lot of outsourcing, subcontracting,
Hmm.
non having as few employees as you can. If you think about the gig economy and how much those large organizations are, really fighting their employer status when it's so clear that they control the work. I did a study of temporary work agencies, which is similar to the construction agency in that you're sending someone to work somewhere else. And although with the temporary work agencies, they were actually employees of the temp agencies, which is different from being a contractor on a construction site. But basically, you're there for convenience of that other employer, and as soon as you're not convenient anymore, off you go, right? And that's the way the legal liability is set up with these types of structures, is that the employer on the site is guaranteed to have fully productive people there all the time, because if someone isn't productive, they're quickly replaced by someone else, and they don't really have the liability for it. So it's a tricky situation. Although I know in Australia, for instance, with the trucking industry and all the subcontracting, there's legislation that gives the top level contractor responsibility for the health and safety conditions of what happens in the lower levels. And I'm not too sure, maybe people like Sari might know more about that in Canada, but that was sort of a policy solution there.
Yeah, because that seems to be the issue. Like, if the employer, subcontractor employer says, no, I have this fellow, they've been off, they've been to treatment, let's say they've gone to de novo, they're well, they're great, they're ready to go, and there's the employer's like, no, they've been banned, they're not allowed, we don't want
Yeah.
them. And so then you have an employer, then a subcontractor employer, who has a worker that they need to, from a human rights perspective, find some work under
Yeah.
like undue hardship. Yet if you're contracted only with that one company, you don't have other companies you've got jobs with. Which in a lot of small communities, you may be a subcontractor, but it's for one employer and one employer only. There a lot of people seem to be struggling with that. So
Yeah.
no solutions at the table, then, huh?
No, but a good point to raise. Good point to raise. Yeah.
Okay.
Thanks a lot, Kathy, and thanks again, Ellen. I think we need to shift to the next segment, and then maybe there'll be opportunity for more broader dialogue at the end too. So